Even though there is no cure for dementia, there are medications out there that can buy you some better function for some period of time. I actually have a patient who's been at home now for 5 years, and I met him in a memory unit. I would caution against stopping these medications.
Yeah, it sounds like the most important one to keep in mind is...
Welcome, everyone, to the Dementia Doc Podcast, where we speak all things dementia, caregiving, and life. I am Dr. Miguel Rivera, and I am joined by my wife, Ganga. And today we're going to be discussing the different medications used in dementia.
Miguel, as far as I understand, there is no cure for dementia. There is no medicine that can cure it. Then what are we discussing? What medications are we talking about?
Even though there is no cure for dementia, there are medications out there that can buy you some better function for some period of time. Some of them better than others, but I think that in general that is a fair assessment. That there are some medicines that, even though they're not curative, yet they are still helpful.
And what do you think maybe the biggest misconception about those medications?
Well, both sides of the spectrum. On one end, there are, people that feel that these medications maybe are curative or that they can work miracles. And then on the other end, there are those who believe that these medicines are just worthless and that there's no point even in trying them. And at least in my opinion, the truth is somewhere in the middle. I believe, and it's been also the experience in my own family, that these medications can definitely help in this path of dementia.
So what are those medications and how do they work?
So in general, there are two main classes. We have the older medications, which are the acetylcholinesterase inhibitors, because they inhibit the enzyme that breaks down the neurochemical acetylcholine, which is one of the most important neurochemicals as they relate to learning and memory and cognition. The other type of medications or medication are the ones that work on the neurochemical glutamate, which is the main excitatory neurotransmitter in the brain, and it is also intimately related or important for learning and deposition of new memories, including cognition, etc.
So I would imagine if someone has a family member with dementia, they don't know even how to navigate those waters. So when should they think of medications? How do they choose them? What do they do?
Okay, so in general, the medications that work on glutamate, like the memantine, that's a class of medications or a medication that is typically reserved for those who have moderate to severe dementia. If your loved one or the person with dementia is in the earlier stages, like perhaps an early dementia or even mild cognitive impairment, then the acetylcholinesterase inhibitors, so medications like Aricept or donepezil, rivastigmine or Exelon or galantamine, Razidine, are the examples of this class of medicine. And they actually have been shown to work in people where the disease is milder.
So when do people need to begin the medication? At what point do they start?
Well, so I think that kind of maybe opens another line of reasoning, which is, when should someone get checked out? Because if you don't get yourself checked out, you're probably not going to start on one of those medications. So I remember one of my professors at my residency program used to always say, time is of the essence when it comes to memory problems. He always wanted to make sure that we understood that there's no time to waste when it comes to memory problems. particularly, like you mentioned, because there is no cure. So anything that you can do to begin to improve cognition can have profound long-term effects on the person.
So let's say if a family member notices some cognitive issues, they need to be checked out. And then if there is, let's say, mild cognitive impairment, do they begin the medication then, or is there a certain demarcation line?
So, there are different types of mild cognitive impairment, in general, amnestic and non-amnestic. So amnestic comes from amnesia or memory loss. And this is the type of mild cognitive impairment that tends to progress. There is a fair number of cases that will progress to develop Alzheimer's disease. I think maybe 35%, something like that. And so for the amnestic mild cognitive impairment, or for the early stages of Alzheimer's, then it makes sense then to start a medication like Aricept or Exelon or Razidine, whichever one you and your doctor decide upon.
And how long does it usually take for medications to begin to work?
Several weeks, because most of these medications you begin at a lower dose, and then, like for example, the Aricept, for the immediate release formulation, you begin at 5 milligrams once a day for a month at least. And if the person is tolerating the medicine okay, then you go up to 10 milligrams. If we're talking about the memantine, then it's kind of similar. So you begin, for the immediate release formulation, you begin with 5 milligrams once a day for 7 days. Then you go up to 5 milligrams twice a day for 7 days, then 5 and 10 for 7 days, and then you end up at the target dose, which is 10 milligrams twice a day.
But do people feel the effects at the first doses or once they reach the target dose?
So, in my experience, the people who really show better improvements on the medications begin to show improvement earlier on. So I would say that for the cholinesterase inhibitors, it may take from 3 to 5 weeks to maybe even a couple of months. And the same for the memantine. It takes about a month approximately to increase the dosing schedule. And then you at least want to give it another month before you say, well, this medicine was helpful or not.
So when you say early on, it doesn't mean in a week or 2 weeks. It still means maybe 4 weeks, 5 weeks.
Yeah, not typically. It's not that quick. It's not, like we think of an aspirin, you take it and then things get, the headache goes away. So these are medicines that definitely take a longer period of time before people begin to show some benefit.
What about alcohol? Because I can imagine a lot of people like to have their glass of wine or a beer. And now if they begin to take those medications, should they be taking anything into account regarding drinking alcohol?
Two things to consider. So number one, psychiatric medicines in general do not mix well with alcohol. So whether you're taking medications for anxiety or antidepressants or cognitive medications, it is better not to drink alcohol with them. Now, if we're talking in particular about medications for dementia like we are, then that also raises the concept that, like they say now, there is no safe amount of alcohol for the brain. So if the person has mild cognitive impairment or begins, through the earlier stages of dementia, it is really worthwhile to begin to significantly curtail or even eliminate the alcohol, both for the effects on the medications, but also because it is something that is considered neurotoxic and that it can accelerate the progression of the dementia.
I think I also heard you mentioning dizziness as one of the side effects, and that can also compile with the alcohol effects.
Yeah, alcohol is an important thing to talk about because both of these medication classes, whether it's the cholinesterase inhibitors or the NMDA receptor antagonists, both of them have dizziness as one of their most common side effects. So you definitely don't want to take something that is going to make you dizzier even, because of course in this population the thing I'm immediately thinking about when you mention that is falls. So we do not want to give people things that can make them more likely to have a fall.
Mm. And what are other side effects of these medications that people need to know about?
So when we talk about the cholinesterase inhibitors, so this, like I mentioned, dizziness is right at the top of the list, and then also pretty significant GI side effects. So things like nausea, vomiting, diarrhea, and one of the main reasons why I have to stop these medicines after the persons have been on it for quite some time is that it can influence the appetite. And I think that that is something that I see a lot as the patients progress from the earlier stages of dementia through the more moderate to severe, is that people begin to not want to eat.
Mm.
And so that is one of the main reasons why I stop the medication, or at least cut in half the acetylcholinesterase inhibitors. Also, some of the other side effects can be, for example, acetylcholinesterase inhibitors can have a significant effect on the heart. They can slow down the heart rate, and they can also interfere with the contraction of the cardiac muscle. So those are some really important side effects, GI side effects, and also the ones as they relate to the heart, again, because that can lead to falls.
Mm. And what do people
Now,
do if there are side effects?
well, so the most important thing to do is to follow the manufacturer's recommendations of starting at a lower dose and slowly increase the dose. I think that a lot of the times when I see people with side effects, it's because they started at the, like for example, started the Aricept at the 10 milligram dose, as opposed to starting on the 5, waiting a month, and then increasing. So sometimes, the person may not be able to tolerate the full dose, but can actually tolerate the smaller dose. And sometimes I definitely do that. Actually, I forgot to mention the side effects from the other medication, the NMDA receptor antagonist, or the memantine, or the Namenda. So again, at the top of this list is dizziness and also confusion, headaches, and constipation. And this is, it opens up an interesting point, and that is, I hardly ever start the acetylcholinesterase inhibitors first, because if you start the memantine first, because it tends to constipate, it actually makes the cholinesterase inhibitors better tolerated.
Mm.
So that's a little trick of the trade. Maybe start the memantine first and then add the cholinesterase inhibitor.
Mm. And that is true for people even earlier in dementia, because you mentioned that most people in the earlier stages take Aricept and then later Namenda. So you're saying that even in the earlier stages, maybe start with a little bit of Namenda and then Aricept?
Well, I was actually thinking about more my population, which is in my practice, I don't see very many people that are in the earlier stages. I don't believe that the Namenda has really, or the memantine has really shown itself to be particularly effective in the earlier stages of the disease. So I was thinking more like my population of patients, more the moderate to severe, which are the patients that I typically see.
So then, even at those stages, you have some patients that are not taking any of those medications, that you actually need to start them on one of those?
Oh, all the time. Yeah, all the time. I think I maybe have started memantine, like hundreds of times for sure.
But were they already
Even in my population of people that are already moderate to severe in their disease journey.
but were they already taking Aricept, or some of them were not taking any dementia medication?
Some of them were not taking anything at all, and some of them were taking a cholinesterase inhibitor like Aricept, and that brings up an important point, and that is that you can use these medicines together. And there's actually a study that came out several years ago where they had people who were stable on Aricept and had taken Aricept, I think, for a couple of years. And then they added the memantine on top of the Aricept. And those people had significant improvement in their cognition, activities of daily living, etc. So both of these medications work, let's say, in a synergistic manner. So because they work on different neurochemicals in the brain, they can potentiate each other. And many times, the combination makes them better tolerated.
But do we need again to stress that that is true during moderate to severe dementia, and not the first stages of dementia?
Well, because I don't think that you would start the memantine or the Namenda in the earlier stages. So yes, everything I talked about just now was for moderate to severe.
Okay. And when you studied people on those medications, have you seen dramatic improvements in your practice?
Oh, totally. I mean, I think that the first example that comes to mind is my mom. And, she's been on memantine now for 20 years. And, when she first started taking it, my dad was very concerned about how she was doing. And, she was one of those people that had a really dramatic improvement on the memantine. And she, it's been 20 years and she has really leveled off. She has hardly progressed through the disease process. It's been, quite amazing. And I've also had patients who were in a memory unit already. And I started them on the memantine and they were able to go home. They still had dementia, so it's not like it cured them, but it improved their function so much that they were able to return home. I actually have a patient who's been at home now for 5 years, and I met him in a memory unit.
And I think it's such an important point for people to understand that, as we mentioned, even though they're not curative, to buy 5 years, 20 years of better functioning is huge. It's huge for the person, it's huge for the family, financially, health-wise, psychologically wise. So the benefits of those medications are incredible.
Well, and of course, not everybody has those really dramatic improvements. I would say that most people that I start on memantine, for example, have some improvement, and perhaps maybe 5 to 10% will have more dramatic improvements on it. So, but at least there is some improvement on everybody, whether it would be, for activities of daily living, or improvements in memory, or less agitation, less, delusional thinking. So yes, I think the memantine is a good bang for the buck.
Mm-hmm. And I would imagine that there are some families, while dementia is progressing, the functioning of the person is also declining. And so they may think, why would they take that medication if the person is declining anyway? So what would you tell those people?
I would caution them against discontinuing the medication unless there is a side effect, or unless they're, like, for example, I just mentioned that many times when people begin to lose their appetite, I will I will pull back on some of these medications, particularly the cholinesterase inhibitors. So, in the absence of a side effect or some reason why those medications should be stopped, the data shows that people can have a significant decline if you stop those medications, particularly if you stop those medications abruptly. I had a patient at one of my facilities where the wife came with basically that same argument. My hubby is getting worse. These medications are not doing anything. I think I want to stop them. And in particular, this person was on Aricept at that time. And I told her, I said, maybe let's taper it off, and then we can see how he does. And then if he does okay, then we can maybe discontinue it. But she wanted the medication stopped, so I did. And within a couple of weeks, the patient had it's like he fell off a cliff, had a dramatic decline to the point that, for example, previous to me discontinuing the medication, he was able to participate in his activities of daily living. He was able to feed himself. He was able to drink. And all of a sudden, they would sit him in front of his food plate, and he had no idea what to do with the food. He had no idea what the utensils were supposed to be used for. I saw him trying to eat a napkin, so a really dramatic cognitive decline. In addition to that, there was a little old doggy in the facility that was like, the mascot. And he got very upset and angry with the doggy and tried to choke the dog. So I would caution against stopping these medications unless there is a particular reason to stop them.
And is there anything people need to know about how this medications interacts with any other medications they're taking?
So yes, the cholinesterase inhibitors, you have to make sure that they're only taking one. Like a few weeks ago, I was called in to see somebody who was having pretty significant GI side effects, and when I evaluated him, he was on Exelon and on Aricept at the same time. So these medications should not be used together. Another class of medications that to avoid for the cholinesterase inhibitors are the anticholinergics. These are medications that actually block the action of acetylcholine. So, on one end, you're trying to increase acetylcholine by giving somebody Aricept, but then on the other end, you're blocking the effects of acetylcholine. So, also, certain cardiac medications, you need to be careful. And also with medications that affect the, something called the QTC interval, which is an interval in the heart. And when you take multiple medications that can increase the QTC interval, it can lead to arrhythmias or abnormal heart rhythms. Now, talking about the memantine now, or the Namenda, so you want to avoid other medications that interact with the NMDA receptor, and these are things like dextromethorphan, and dextromethorphan, for example, is in cough syrups and cold medicines, so it's something you can actually get over the counter. So it's important to know that that's one of them. Also, ketamine is another medication that hits the NMDA receptor. There's also amantadine is another medication. But I think it's really important that before you start any of these medications, that you discuss them with the doctor. Maybe go online. There are many drug interaction checkers there, so that you can see whether any of the medications that your loved one is currently taking can interact with some of these medicines, and then of course discuss them with your doctor or your primary care or neurologist, whichever practitioner you're dealing with.
Yeah, it sounds like the most important one to keep in mind is the cough syrup, because everything else you're not going to start without a doctor prescribing it to you. But just to
Right.
go and get it at the pharmacy while your loved one
I
could be
agree.
taking the med there, that's a very
Absolutely.
important one to know.
Yes, I completely agree.
Sounds like a good point to complete our podcast, unless there is something else you feel people need to know about these medications.
So I feel that the take-home message is that these medications can be helpful. You know, they are definitely not curative, but they are not worthless either. And that, particularly with the memantine, it can definitely buy you some better function for some period of time. And for some people, it might be a modest improvement for several months or a year. And for some people, like my mom and some of my patients, it can be a significant enough improvement that you can actually go home and resume your life at home. And I say that, Namenda is the best bang for the buck. I feel that anyone who is in the moderate to severe stages of the disease, if there is nothing there precluding its use, I think everybody should be tried on memantine.
Thank you everyone for listening. And if you have any questions or if you have any topics you feel we should discuss, please leave them in the comments. We appreciate your time.
Thank you for joining us.